excited to present the first of a women's health series for Women Who Win in collaboration with the Indian Medical Association of New England. I am your moderator. My name is Deepa Javeri, and I'm a podiatrist. I work at 2 Boston Medical Center health centers, as well as the Beth Israel Leahy Health Center here in Boston. Today's topic is one that we've all probably experienced at some point or the other. It's foot pain. And a cliche as it sounds, when your foot hurts, your whole body hurts. And so today we have 4 podiatry experts from across the globe, and I'd like to take a minute to introduce each one of them. Firstly, I'm going to introduce Dr. Emily Howarth from Cork, Ireland. Emily has been in practice for 25 years and is the National Education Officer for Podiatry in Ireland. She works at Bantry Hospital with acute foot infections, and she also has her master's in high-risk lower limb. Next, we have a local Bostonian. We have Dr. Sarah Rose. She works at Massachusetts General Hospital, and she has studied at Barry University in Florida. She has a bachelor's in behavioral neuroscience from Northeastern University. Welcome, Sarah. Our next speaker is from Northern United Kingdom. We have Dr. Jill Halstead. Jill is the clinical head of podiatry service at Leeds Community Healthcare Trust in the UK. Welcome, Jill. And then we have Dr. Denise Bonin from Staten Island University Hospital. She went to school at Temple University in Philadelphia and is currently in private practice in New Jersey. So welcome, Denise. Thank you. I also want to introduce a couple of the folks on the back end. We have Dr. Manju Sheth and Charlene Sheth are the co-founders of Women Who Win. And Charlene is also helping us today set up this Zoom call, as is Dr. Drumil Shah. He is an internist at Compass Medical and is also the president of the Indian New England Medical Association of New England. Thank you for all the technology help on the back end. So let's get started. Ladies, thank you for taking the time to join us today. We hope to get some important questions and topics answered for our audience. How it will work is we came up with a few common scenarios that I'm sure all of us have seen in our practices at some point. And I will present a case, and then we'll talk about some differentials and treatments, and hope to cover some important topics. So with that, I'm going to start with the first topic. The first case scenario, rather. And so this is probably a very common case scenario that all of us, I bet, have seen. A 25-year-old patient comes into your office and says, I just started a new weight loss running program 3 weeks ago, and I'm now experiencing heel pain when I first wake up in the morning. Do I run through this pain? And how do I manage this pain while pursuing my fitness goals? And so, Emily, I'm going to start with you. If you want to just talk about what your initial reaction is, and maybe perhaps some questions and treatments that you might think about.
So heel pain is very, very common, and it's probably one of the most common things that we see in practice, especially with women coming in complaining of sort of like when they first get up in the morning and they take those first few steps and they're in pain, and then as time goes on and they're walking around, and it can get a little bit easier, and then maybe at lunchtime they sit down, and about 10 minutes later or half an hour later they get up, and then again it's there again. And this is kind of typical of sort of a plantar fasciitis, as we call it. Your American accents pronounce it a little different than we do. And so what the fascia is like a sort of inflammation of a thick band of tissue, basically, which connects your heel to your toes, and this is called the fascia. And it kind of helps with absorbing shock and things when you're walking, and supports your foot arch as well. The stress and the tension in it get a little bit too much. There can be a variety of reasons why this fascia starts becoming a problem and getting irritated. Lots of them are occupation and standing a lot, carrying that little bit of extra weight that we'll do. Foot mechanics, how your foot behaves when it's walking, and is it walking with a really high arch or low arch, and footwear as well play a big role in this. Not having enough cushioning under your heel and things, or a non-supportive shoe for a foot that needs more support and things like that. And typically, it get up in the morning, you usually get that really horrible pain, which eases a little bit, and then every time you relax and rest, and again get up again, it usually starts again. So, so this is typical of plantar fasciitis, and in this patient here, she just started running 3 weeks ago, and she's now experiencing heel pain. It could be plantar fascia. I'd sort of tease out when she's getting the pain and things, or it could be a trainer or footwear issue as well, or not following a proper program in running and things. Generally with lockdown and things and COVID, we're seeing a lot more sort of sports injuries coming in because we're all out running and jogging and doing everything within our 5K radius and things.
That's great, Emily. Thank you. Yeah, and like you said, this is a very common condition that we see at least once a day, if not more, right?
Yeah, absolutely, absolutely. Yeah.
And so, Sarah, I'm going to switch to you next. In terms of what would make the patient, what would make us, or I guess the patient, rule out perhaps a stress fracture? Maybe if you can talk about that for a few minutes.
Yeah, so stress fractures is another thing, again, with COVID, with people changing their activity levels, that can happen. So with stress fractures, usually what happens is you've sort of increased your activity level. Sometimes it's a recent weight gain, and all of a sudden your foot kind of starts to hurt, and it hurts every time you put weight on it, as opposed to sort of just the first steps in the morning, like that plantar fasciitis scenario. Usually stress fractures kind of hurt every time you're putting weight on it. You may get an x-ray, and it may say absolutely nothing on the x-ray initially when your pain first starts. And that's sort of typical of stress fractures because it's not an actual crack in the bone, it's sort of deeper inside. So usually in those scenarios, you kind of rest for a little bit, and then you go back and check on it in a few weeks with another x-ray. If it truly is a stress fracture, you do need to get off of the foot, so it is worth getting it checked out. As opposed to sort of like a plantar fasciitis or a tendinitis, which you may treat a little bit differently.
That's perfect, Sarah. Thank you. So now that we've ruled out stress fracture for this patient anyway, Denise, would you like to talk about maybe footwear and what kind of changes or suggestions you might make with for this patient, and or orthotics, what your recommendations would be for that?
Sure, Deepa, thank you. So especially during COVID, like we're seeing a huge uptick in foot pain, most secondary to poor shoe choices or lack of shoe choices. I have patients coming into my office that are home 24/7. They're working from home via Zoom or via virtual private networks to get into work. They're not leaving the house to go to the gym like they used to, so they realize I need to keep up my fitness program at home. I have many patients saying I'm now running barefoot, or I'm running in my socks and and slippers and things like that. So I try to advise patients to have a proper running sneaker if they're going to be running inside on a treadmill. If they're going to be outside on the pavement, same thing, a proper running shoe, not a fashion sneaker.
Thank you. And so Jill, I'm going to move to you to just talk a little bit about, and I often have to sort of rack my brains for this one. When we tell patients to stay off their feet, for extended periods of time because of plantar fasciitis or a lot of other things, stress fractures and such, what are some alternatives in terms of patients who are very active and need to exercise? What are some alternatives that you would suggest for them?
Yeah, this is a great question, and it's one that I think patients struggle with, particularly in a younger group. So just particularly in this case, I wouldn't expect, if you've not got pain all the time, you've got more intermittent patterns of pain, that actually having a level of activity is okay alongside this particular condition, and in circumstances where other more serious things like fractures have been ruled out. What we do know is actually running is really beneficial for your health, and I think it's really good to have a public health stance on this, that actually being fit and active. So what we want to do is keep people going, but it's keeping that balance with the tissue pain, but also keeping you active. The other thing just to bear in mind is with heel pain, there's some good research around how strong your muscles are and whether you've got good flexibility at your ankle. So actually building in an exercise program that builds in that muscle strength around the ankle and the foot, and also stretching around the ankle, you may be getting more pain during running because your ankles start to get stiffer, and that's sometimes because you're weaker and you've started a new program. So what I would always encourage is keep the activity up. We all know it's really easy to be in the activity zone, but when you fall out of it, man, you can fall out of it. So actually, let's stay in the zone, but let's find something you really love, that you absolutely get excited about, but there's maybe not got that really repetitive stress. And that could be, for some people, switching to activity like a cross trainer if you're at a gym. It could even be like treadmill has got slightly more impact attenuation, so less pressure at the heel than, say, in concrete. And trying to find those, what we'd say, like mix it up a little bit more. Some people who are serious runners and that's their dream, I kind of push them onto something like triathlon type approaches, so that they get a swim and they get a cycle. They could do that within a club scenario. But I think I completely agree with all the ladies said. It's so individual, but I would just try and find those alternatives. If you're an avid runner and walker, even poles works. There's really good evidence poles reduce the stress through the foot. So if you wanted to like do some fast speed walking with poles, that's really good to take the stress off. I think always just look for those alternatives, try and tweak it. Let's keep you active and keep what you love. But as long as all your things are ruled out and you can keep that strength up and that flexibility.
That's great, Jill. Thank you. Another thing I usually recommend to patients, which doesn't always work, especially with this weather, is to switch to swimming, which is a non-weight bearing activity. And if they need to stay off their foot, as long as they can get their foot wet, I guess. That's great. So I'm going to actually switch to the next case scenario. I have a 73-year-old mother is a diabetic. When I took her out for lunch recently, she slipped and has had some ankle pain since then. How can I tell if she has a sprain or a fracture, and should I take her to the podiatrist?
Yeah, if you ask everyone in a room to put their hand up with an ankle sprain, every woman put their hand up. This is incredibly common. What we worry about is when ankles become unstable over a long period. So in someone who's a little bit older, depending on the condition, we can't be ageist. You could be in good condition. You could maybe not be in good condition, i.e. how is your strength, how is your balance? So from my perspective, is always around how did the sprain happen? So we focus a lot around what exactly went on. So for me, it'd be really important just to make sure that you've got that really good history about did they fall off one step or 3 steps? Did they go down quite badly? Did the ankle twist a lot? The really good evidence is around how well they recover after. So can they put the weight through it? Can they stand through it immediately after? If people cannot put their foot down at all, then for me, that's a little bit more, the alarm bells going off. You need to seek some help. Okay. When someone's a little bit older, we worry their bones are a little bit thinner as well. So for me, if you can't put your foot down immediately, you've gone with a big fall, you've got a history of fractures, you've got a family history of maybe fractures, then go seek help, go to your emergency room. Let's make sure that we've not missed anything, and let's get that seen to. If the person can put their weight through it and they can take a couple of steps, the magic number is around 4, then actually that might be more of a sprain. But you need to look after yourself. Unfortunately, sprains can be nearly as bad as fractures in terms of recovery. So even though you've got one diagnosis over another and the management's very different, have to say it's a bit of a long haul, unfortunately, unless it's very minor. But minor ones are very common.
Right. That's great. Yes, absolutely. I see ankle sprains almost every single day. And yes, it's almost a little depressing to have to tell patients because they think it's just a minor little, they just stepped off the curb perhaps. But yes, and so segueing right from that into ankle fractures, Sarah, if you want to talk a little bit about, what things might cause ankle fractures, what to look for, and a little bit perhaps about the treatment and surgical treatment of ankle fractures.
Sure. So most ankle fractures end up happening from something extremely simple. Most of them are someone slipped and fell. And just one thing to sort of add on the diabetic patient, a lot of times people have what's called neuropathy, so they don't feel everything. So sometimes, usually ankle fractures hurt a lot. It's typical of the diagnostic. If you can't step on your foot, definitely get an X-ray. But just a kind of word of caution, if the person does have neuropathy, so if they're diabetic, very commonly it's associated with that, they could possibly be walking around for weeks, and I've seen that commonly, that they've been walking around for weeks with a little swelling and ends up being fractured. So, definitely if there's a concern for any fracture, or any swelling, severe swelling after a fall, after kind of twisting your ankle, make sure you get that checked out with an x-ray. But if you do have a fracture, often you do need surgery. And that involves a period of being off the feet for about 6 weeks. So it's definitely worth sort of getting checked out and just being careful with maybe some family members that might not have full sensation to their feet.
Great. Thank you. And Emily, Sarah touched a little bit on diabetes, but I'd like you to talk a little bit more in depth as to what this means for a diabetic patient to go through this. The 73-year-old mother is a diabetic, and so what are some of the concerns that we would address, from that perspective?
Yeah, absolutely. So obviously if you're diabetic, feet become very, very important, and it's really important to see a podiatrist regularly for checkups and things. But two things can happen simply with feet if you are diabetic, and you can be at risk of developing something called neuropathy, which is just mentioned there, and peripheral arterial disease as well. All these risks can be reduced with correct blood sugar. If you can control your blood sugars really well, the risk of developing these is much lower. Smoking, cholesterol, blood pressure control, exercising regularly, and the healthy eating, everybody will know all these from being diabetic. So developing complications of neuropathy or peripheral arterial disease can be much lowered, the option of developing these by keeping everything else controlled. If they do happen, so neuropathy means you've lost your pain sensation or feeling in your feet. So you could stand on something without realizing you've stood on there. Pain is usually our indicator to let us know when there's a problem. And when we can't feel pain, you can wear shoes which are too tight and form a blister. You can stand on something, as I said, like a little nail or whatever. You can walk barefoot. It's much more frequently you can get damage on them. So people can actually go for days and have a problem in the foot without realizing it's actually there. And this is one of the dangers with it. Peripheral arterial disease as well can develop in the diabetic lower limb and foot, and this can make your circulation not as good coming into your foot and things. So if you do develop a wound or a cut or something, if you have peripheral arterial disease, then healing it becomes a little bit more difficult as well. So looking after your feet when you're diabetic, one, seeing a podiatrist regularly, and the podiatrist can assess you for all of these and let you know whether you have neuropathy or whether you have peripheral arterial disease. So you know your level then, and how often then you need to be seeing somebody, and how careful you need to be with your feet as well. Looking after your feet is obviously very, very important, and I try and get my patients to sort of check their feet once a day. So you know, if you look in the mirror, whether you have a new spot or you have a red area, or you're not looking as good today as you did yesterday. So I try and get them to look at their feet as you would your face. So know them as much as you would your face. So you know every morning when you check your feet, or every evening, toes are all there, everything's fine, I've no colour changes, I've no cuts or wounds or new bumps and lumps kind of thing. So off you go and do your day, which is grand. If you develop something, then you'll know yesterday it wasn't there and today it is. So you're straight immediately, you're within a 12-24 hour framework to go and seek help with it then as well. Footwear is really important, and wearing a shoe that fits you, which is wide and deep enough to take your toes, is really important. And again, what I usually tell my patients to do, because people don't believe you when you say that actually the shoes don't fit properly, or you're trying to get somebody to do a larger shoe size and things like that. So I usually get them to stand on the cereal packet, the actual cardboard part of like your cornflakes or cereal, and draw an outline of your foot, and then cut it out and then pop that into your shoe. And if it comes out crinkled at the edges, this is what it's doing to your foot. So it just gives people an idea, a visual idea of whether these shoes are fitting you or not. It's always best to get them measured anyway. Cutting your toenails straight across. If you're neuropathic or you have peripheral arterial disease or your circulation isn't very good, it's not advisable to do your own feet anyway, and you should be going to the podiatrist regularly for care. putting your toenails straight across, any corns, callus, any problems with your feet like that, you should be treated by a podiatrist as well. Don't try and do this on your own. And then there's certain situations where you need to urgently go to your podiatrist, as when you have a cut or a wound on your foot. It can sometimes develop into long-term wounds, or you see any colour changes to do with your feet as well. But yeah, so I'm a diabetes pod in Ireland, so we see a lot of problems coming into the hospital there. But it's great to be able to try and prevent this, which you can do.
So our third case scenario is a 50-year-old woman, and she complains of, she says, I recently bought a new pair of shoes and now I am experiencing numbness and cramping in my toes. Is this normal, and or should I wait for them to just break my shoes in? And what types of shoes are best for working women's feet in particular? And Denise, if you can start with your initial diagnosis for this patient and thoughts on that.
Sure, thanks. When patients come in and they say they have numbness or tingling or burning sensation at their toes, I usually ask them, how long are you wearing shoes? What sort of shoe are you wearing? And when does the pain occur? If you fall in love with the latest pair of gorgeous pumps in the store and you must have them, but they're a little tight, they're probably not going to break in. Some shoes don't fit every foot. If a shoe is too tight across the toes, or if they're too pointed and the toes are being squeezed, there's nerves that run into your toes that are being squeezed. When a nerve gets squeezed or pressed upon, they get angry. When they get angry, they will tingle, they will shoot electric shocks, kind of things like that. So as much as we as women love shoes, it's really important to find a proper fitting shoe. Luckily, I think the pointed pump is kind of going out of fashion now. Working from home, we don't have to wear our pumps anymore. So I do recommend, if you are going to wear a heel, 2 inches or less. I am a big fan of Wedge shoes. They tend to distribute the weight properly, a little more evenly across the bottom of your foot, and not too pointed of a toe, more of a rounded. You want to be able to at least wiggle your toes a bit. Otherwise, it'll be angry and it'll get back at you.
Yes, absolutely. And then, Jill, if I can have you speak about probably the most common condition we see sort of across the board, but probably more in the younger to middle-aged and probably older age group too, is, as one of my patients put it, onions, bunions, and hammer toes. If you want to touch on that, Jill, please.
Yeah, unfortunately our feet change a lot as we get older. Again, it's one of those secrets no one really talks about. Hair changes colour, but our feet change. And what we still do, we have this perception, maybe it's like when we think we're young, but we're not, and our feet change shape and they can make difficulty, particularly with footwear. We focus quite a lot on footwear, but we need to understand that. So bunions, where they can get bony lumps that are kind of next to that big toe that can grow, and that lump can either be on the inside of the toe, it can be on the top of the toe, but it does make fitting shoes really difficult, really challenging. It does run in families, particularly in women, and particularly if you get those problems much younger. So that's something to watch out for. So you maybe need to go and examine your mum's and your grandparents' feet and take stock, unfortunately. And the things which talk about hammer toes, those really curly toes that come up, they can happen associated sometimes with these bunion changes, but they can happen individually. It's just really important to look at those early changes, really think about what your shoes are doing to exacerbate or make that problem worse. Unfortunately, whether it's rubbing, you can get little bits of fluid under the skin that can aggravate and become quite burning at times, or even blister. So as women, if you get these lumps and bumps, it is time to kind of look at those other footwear manufacturers, really think about a variety of shoes that can support your foot. But yeah, and unfortunately in some cases, because bunions are really common, it's about 1 in 4 people, but about only 5% end up or for my statistics in the UK, end up in surgery. So actually a lot of people do quite well with it. They might have a lump and bump for a while, but they live with it. So the vast majority do okay, but some people don't, and they can get more of what they call like an arthritis type of pain. It can be chronically aching. It can be worse sometimes with cold weather. That's actually been proven now, by the way. Everyone used to say, grandma used to say, it's bad in weather. They did a big Manchester study, Manchester, where it rains in the UK, and they proved it. So it is fact. And it's important to just recognise you might have a bit of arthritis. But again, it's up and down. It can be stable. It's not something to worry about. If you get pain that's progressively worse over a 6 to 12 month period, and you're just not managing very well, then that's the time really to kind of seek advice. But you may have to think about more invasive, more solutions. And there's some great surgeons on here that I'm sure will give you some advice on that.
Yes, absolutely. I think you covered it all, Jill. And so, Sarah, I was going to ask you to talk about in conjunction with hammer toes and bunions. Another common thing that we hear about is the pump bump. Can you talk a little bit about that, what that is, and what it means, and treatment options for that?
Yeah, so that's very common. It's a little bump. It's on the back of your heel, so not on the bottom, but on the back. And they call it a pump bump because it actually felt better when people wore pumps. Because when it's attached to a tendon in the back, your big Achilles tendon. And so when patients wear pumps, you're taking some pressure off of that area. Usually it's treated non-surgically in the vast majority of patients. A lot of times there's a bone that actually forms in that area, but most of the pain is due to the inflammation around that big Achilles tendon. So if a patient initially comes to me with a pain and a bump in the back of their heel and we've ruled out everything else, usually we start with some form of an exercise program, whether that be with physical therapy or just starting some exercise they do at home along with reducing the inflammation. And then we give that a good amount of time. Every once in a great while, it does need to be treated with a surgery, which is pretty invasive, and we avoid it if at all possible. But the vast majority of time, even if there's a little lump in the back of the heel, we can manage to get the pain to go away. And like I said, it's mainly due to a big tendon attaching onto a bone. So if you see a big lump on the back of your heel, it doesn't necessarily mean the bone needs to get shaved down just yet. A lot of times there's a lot of inflammation and a lot of different shoe gear options, as well as like physical therapy or exercise programs that can be done to really reduce a lot of the pain.
That's perfect. And I have seen it more in patients who try to wear heels and already have a enlargement in the back there. So that's a pretty common condition too. And then I know, Denise, I'm going to move to you lastly, and this is again probably across the board for women, men, children. We hear this all the time. Blisters from shoes or from other activities. Can you talk a little bit about that and treatment options and when it's serious enough to go, get it checked out?
Sure. So a blister is an irritation of the skin, most of the times caused by friction. So poorly fitting shoes, sometimes too tight, and actually sometimes too loose as well. Anything that's going to be rubbing due to ill fit can create a blister. A blister is just a fluid-filled sac. Oftentimes I tell my patients to leave them be. If they're really bothersome, you can use like hydrocolloid band-aids. They're almost like a band-aid that can stick to your foot. They stay on for almost a week at a time if you let them. They just give you an extra layer of protection where the rubbing is. You can obviously get a better pair of shoes that isn't rubbing, but if you really, really love them, I often will pad off my patient's shoes with silicone tape or even moleskin, which you can buy over the counter. If it's more of a blister from a burn, that's obviously something that we need to treat. As we were talking before, if you're a diabetic and you're insensate or you have poor sensation, you can burn yourself and you won't feel it because you've lost that pain sensor. So if you look at your feet one day and you have a blister that wasn't there and you can't remember how you got it, it's a good idea to have it checked out. If the fluid inside, if the blister opens on its own, the fluid is purulent or dark colored, smells funny, give us a call. I always tell my patients I'd rather keep you well than make you better. So you think simple things is just knowing what your feet look like on a day-to-day basis, know what sort of shoes fit you properly, know what sort of activities you can do safely, and that'll keep you out of my office.
Yes, and that was the goal of this talk, was to keep people, out of the office, but know when it's time to call us and come into the office. And so that was our last case scenario, and we're going to end there. And I hope we've touched on a lot of important and common, issues and topics that people see and go through every day. These are some of the solutions we're presenting from all over the globe. So thank you. I want to thank all the speakers. Thank you so much.